All right. Good evening, everybody. I'm Charles Bacos. I'm a thoracic surgeon at Temple Hospital in Philadelphia. It's my pleasure and the ECTSS pleasure to host a webinar on surgical ergonomics. We have two speakers tonight. We have the honor of having Dr. Joseph Durrani, who's very well known to the CT surgery community. Just as a quick introduction, he is the former president of the STS, and he's held many leadership positions, including he was the chair of the Division of Cardiovascular Surgery at the Mayo Clinic, and he's currently the chair of the American Board of Thoracic Surgery. He has many clinical interests, and we're lucky that among them is surgical ergonomics. He's authored hundreds of papers, and we're very lucky to have him tonight. Thank you, Dr. Durrani.
Thank you for the invite.
We also would like to introduce Dr. Guisong Lee, who has a PhD in biomechanics, who's held faculty position as well at the University of Maryland in the Department of Surgery, who's done a lot of research on surgical ergonomics, who's also held a position at Johns Hopkins, was Director of Robotic Surgical Education. He's currently the Assistant Director of Simulation-Based Surgical Education at the American College of Surgeons, and he's the ACS Surgical Ergonomics Committee co-chair. Welcome as well, Dr. Lee. And thank you for joining us.
Thanks for the invitation.
And I would like to introduce my co-moderator, Dr. Afshan Ehsan, who is a cardiac surgeon at Brown University, who's also the director of minimally invasive cardiac surgery at Brown. Thanks again.
Thank you.
Okay, so we'll first start with Dr. Lee. He'll give a presentation on surgical ergonomics. We'll take questions in the Q&A box. We can address those as we move along. Dr. Durrani is probably going to have to go to the OR soon. Again, we appreciate your being with us, but we'll leave the floor now to Dr. Lee. Please go ahead.
Okay, can you see my presentation?
Yes.
Wonderful. Yeah, thanks again for your the invitation to this webinar. I am so honored to be here to give you a talk on ergonomics in surgery today. I received a clinical research grant from Intuitive Foundation as the principal investigator. The word ergonomics is not a strange one to us any longer. In fact, it has become one of the most essential characteristics of any new product for our daily life. Ergonomics is the application of scientific information concerning humans to the design of objects, systems, and the environment for human use. When we talk about ergonomics, there are 5 main principles to consider: safety, comfort, ease of use, productivity, and performance, and aesthetic. It is well documented that the increased workload from poor ergonomics may substantially worsen surgical performance, causing increased error. When I was in academia before coming to the ACS, I conducted 2 ergonomic survey studies. One of the key questions I always ask was this: have you ever had any physical discomfort or symptoms you would attribute to your surgery practice? My first ergonomic survey study was on laparoscopy, and it showed that 86.9% of practicing laparoscopic surgeons reported suffering from physical symptoms and complications. When we correlate the symptom report rate to the demographic data, our result showed something interesting. We found that age was not correlated with the symptom report rate. However, it was found that those with a high case volume were more likely to report the physical symptoms or complications. The most commonly reported issues by laparoscopic surgeons was neck pain. When the robotic surgery technology was introduced, many expected that the ergonomic challenges associated with laparoscopy would disappear. My ergonomic survey on robotic surgery showed that 56% of participating robotic surgeons still reported experiencing physical symptoms and complications. The most commonly reported issues by robotic surgeons were neck pain and finger fatigue. Both surveys asked the surgeons what they did when they experienced some symptoms during the case. While many surgeons tried to change their posture, switch instrument, or take a break, still more than 1/3 of surgeons simply tried to ignore the problem. After working with many surgeons for the last 2 decades, I found that not all expert surgeons necessarily know how to make their OR setting ergonomic, as they did not have a structured education in surgical ergonomics. Why is the surgical ergonomics with the surgeons important? Surgeons' career longevity is at risk. A recent report showed that the US expected a growing shortage of surgeons. Between 2000 and 2020, the US population grew by 18%, whereas the workload of the general surgeons increased by 31.5%. This implies that more surgeons will likely develop physical symptoms and complications. I hear many surgeons stop their practice earlier because they could no longer endure the physical symptoms caused by the bad ergonomics in the OR. How are we handling the current ergonomic issues with the surgeons? It seems that most surgeons do not discuss their ergonomic issues with someone else. Surgeons may not want to tell their hospitals that they are experiencing physical symptoms or complications that may affect their surgical performance. Also, surgeons usually do not have much help from the hospitals. When I was at Johns Hopkins, I received a phone call from the hospital's workplace safety office, and this is what I was told. A bariatric program had 3 surgeons, and the 2 older surgeons already had the neck issues, and they had the joint fusion surgery. And the third, the younger surgeon, was getting there, so he reached out to the safety office to get some help. They told me and asked for my help, and they said they're expert with the nursing stations, computer, keyboard, the mouse, but they know nothing about the surgery and nothing about the what surgeons are going through. Unfortunately, this is not a unique situation limited to Johns Hopkins. How much do we know about the surgical ergonomics? When I had conducted a brief PubMed search, 2 keyword ergonomics and surgery resulted in 6,510 publications since 2000. In 2000, there were only 85 publications, but now we are seeing over 400 publications every recent year. So I can safely say that we are now, the surgeons, ergonomic researchers, and scientists have published a lot in surgical ergonomics. Many surgical conferences, including the ACS Clinical Congress, have ergonomic sessions. Rooms are typically filled with several hundred of surgeons, and 10 to 15 surgeons are standing behind the microphone to ask questions. There, I hear the same question I heard 20 years ago. Where do I place my monitor during laparoscopy? What is the right height for the OR table? I have neck pain and back pain. What should I do? At every moment, I wonder why surgeons ask the same question when we published a lot. Well, it was very obvious that the existing ergonomic knowledge had never been adequately delivered to surgeon community. I would like to share some myths and opinions I heard while working in surgical ergonomics. I heard many surgeons saying that the poor ergonomics would have no impact on my performance in the OR. You can say yes or no in your mind, but you don't have to put it into the chat. I consider surgeons a Superman, as many often say. They do not need to eat, sleep, or pee. And also, I recently heard an interesting example from a single institution that had the need assessment conducted for surgical ergonomic education. When asked if a surgeon's existing symptoms affected their surgical practice, most surgeons said no. When asked if they need to leave work early due to their symptoms, most surgeons said no. However, when asked if their symptoms affected their daily activities, most responded yes. So their symptoms are real. And my interpretation of this is that the surgeons try their best to maintain their surgical performance in the OR while trying to ignore the effect of the existing symptoms. The next one is this. Once educated, the surgeons will do what they should do to improve the ergonomics in the OR. Well, not exactly. Some of my research colleagues conducted a research study with surgeons. After learning some ergonomic interventions, the surgeons happily volunteered to implement some of the ergonomic interventions and then report the effect of them back to the researchers. Unfortunately, no data was coming in days, weeks, and months. And the most commonly heard responses from the surgeons was, "I'm so sorry, I completely forgot about it." So, well, what I observed from my surgeon colleagues is this: as soon as the surgeons go to the OR and see the patient, their only focus becomes the best surgical outcome for the patient. They just forget everything else. And I guess that is one of the main reasons why we see many senior surgeons develop the repetitive physical symptoms and complications, because they ignored their own challenges while seeking the best for the patient outcome. When we talk about ergonomics, we often discuss the environmental setup allowing ergonomically favorable initial posture. However, does a good initial posture, ergonomic posture guarantee optimal ergonomics? As you know, the old days, laparoscopic surgeons used the monitor sitting on the tower. So I wanted to compare the symptom report rate between the European surgeons. At the time, most of them were using still the monitor on the tower, and the American surgeons, who most of them who were using the flat screen monitors on the boom. Because by doing with that setting, the American surgeons were able to place the monitor in front of them lower than their eye level, which was believed to be the ergonomic position. When I run the statistics, there was no difference between the European surgeons and the American surgeons. The symptom reported was both high. So after some investigation and discussing this with physical therapists, I learned that actually the initial posture is important. However, the next symptom was coming from the static posture, because the laparoscopic surgeons were looking at the same point of the monitor most of the time without moving their neck around. So let's talk about the robotic surgery. Do robotic surgery always provide the surgeons with good ergonomics? As discussed earlier, many surgeons doing robotic surgery reported experiencing neck pain. Robotic surgeons may have a more static neck posture because when they do operate on the console, they do not move the neck at all. So they have a more static neck posture while operating at the surgeon console. And also, I had a couple of other examples I witnessed in the past. One of my friends who does a lot of robotic cases told me that he cannot move his neck after cases. So I went down to the OR with a camera, and I brought another PhD in biomechanics, wanted to see how he does. And I was very surprised to see that he never touches the ergonomic, buttons, the control buttons. Before him, there was a very small, the resident, did something at the console, and he didn't change anything, but he actually adjusted his body into the surgeon console. And then this is how he was sitting, slouching and the chin out. And he was doing cases like hour, 2, 3 hours, like this. You don't need a PhD to tell him that that is not the right posture for the surgeon doing robotic surgery. And then another surgeon told me, oh, I put my fingers into the back of the eyes every night. And I said, what's wrong with you? So I went into the room, and then I saw him, whenever he was doing a lot of the suturing that time at the robotic console, he was squeezing this controller so hard. I could see his fingernail turning to white because he was squeezing it so hard. You don't need to do it, but some surgeons develop the wrong habit from the beginning and then keep doing it. And I have seen some residents doing it at the simulation lab, and after 2 hours of suturing that time practices, he was shaking his hand like this. And have you seen the robotic surgeons coming out from the OR with their forehead red mark, there? I name it like the glorious the robotic surgeons the rising sun syndrome. So some surgeons tend to push their forehead whenever they need to focus on some difficult part of the procedure. This is very natural. They want to see closer and they want to see better. But by doing it, you don't see anything better, but that is just a human reaction. And as I already told you, the robotic surgery causes neck stiffness because you have a more static neck posture. And if you push your head more, well, unfortunately, it will increase the neck issues even more. When I joined the ACS Division of Education, I discussed to my boss, Dr. Sachdeeva, the Director of the Division of Education, of creating the ergonomic educational programs for surgeons. So about 2 years ago, I established the ACES Surgical Ergonomics Committee. Unlike the ergonomic task forces or committees of other surgical societies, I invited not only surgeons, but physical and cognitive ergonomists, OR and hospital architect, and the physical therapist to develop multidisciplinary surgical ergonomic interventions. I'm co-chairing this committee with Dr. Raman Berger, who wrote many papers in surgical ergonomics. The first project the ACES Surgical Ergonomics Committee wanted to do was creating surgeon-friendly ergonomic the guidelines. Some ergonomic guidelines have already published, but they are so complicated with too many body parts and too many joint angles. And also additionally, the committee realized that many surgeons had never heard the word surgical ergonomics and did not know such a research area even existed. ACES surgical ergonomics recommendations address ergonomics in 4 core areas, including the posture, hand and instrument, visualization, and stress. Each core area has various recommendations, including intraoperative solutions, solutions before and between cases, and the long-term prevention and the maintenance. The ACES surgical ergonomics recommendations also include a set of stretching and strengthening exercises for surgeons. Some can be used in the OR, some can be done in the office, between cases, hallway, even the elevator, and at home. This exercise program was developed by someone with a doctorate degree, the physical therapist, who married a surgeon. So she knew what surgeons are experiencing in terms of bad ergonomics. You can download your copy of ACES Surgical Ergonomics recommendations using this link or the QR code on the screen. Please share this document with your colleagues, including surgical residents and fellows. Here are some recommendations for open surgery. Adjust the height of the OR table to maintain the hand close to elbow height with the elbow at 90 degrees. Ensure the open surgical field has a high luminance using more than 2 lights. Avoid creating shadow caused by the surgeon and or assistant head. When surgeons of different heights are present, the table height may be adjusted for the tallest surgeon. All other surgeons may use a step for the best ergonomics, surely depending on who does how much of the procedures. Have you ever used any anti-fatigue mat in the kitchen? I like it so much, especially when I was washing dishes at the big party. Some study already showed that the surgeons experienced the reduced strains at the lower extremities when they stood on the anti-fatigue mat. Knowing this, I reached out to the manufacturer who sold both the regular kitchen mat and the OR-grade anti-fatigue mat. The product engineer told me that the materials and structures are the same. The OR version has a special surface for easier cleaning, and the price is only 4 times more expensive. Of course, that is the reason why the mat is called the princess mat by many surgeons. There are small-sized mat are available to be used with the steps. Surgical loops often cause a bad neck posture with excessive forward neck flexion. When you use a loop, you may consider using a well-fitted and adjusted, lightweight, and also the deflected, declined loop as you see on the screen whenever appropriate and available. When a foot pedal is used, the surgeons often maintain excessive ankle flexion and a leaning posture toward the other leg, especially when pedals are not being pressed. If there is a divider or ridge between the pedals, it may be used as a footrest. This little change may allow you to reduce the ankle flexion as well as any leaning posture toward the other leg. And these photos are simply showing some examples. ACES does not endorse any specific anti-fatigue mat, ergonomic loops, or foot pedals shown here. When you select the instrument, select the instrument size and shape based on the individual surgeon and the specific task. Use a power grip that engages the full hand for increased strength. As you can see from this picture, when you do not have your fingers inside of the ring handle of the instrument to use the power grip. And use the trigger locks, or ratchets, or other features to minimize the sustained gripping. Okay, for laparoscopy, place the display monitor directly in front of you and with the upper edge of the display at eye level so that the center of the screen will be placed slightly below eye level. The operating table should be lower than open surgery to keep your handle near or below, slightly below than elbow height. This may be affected by the type of the instrument handle. For example, when you switch from the pistol grip instrument to the inline instrument, your ulnar deviation will become so greater. So the table height should be even lower for better ergonomics. Again, to consider using OR grade anti-fatigue mat. Use the instrument articulation or rotation to avoid the awkward wrist, arm, and shoulder posture. Select the instrument handle type, for example, the piston versus inline for the neutral wrist posture. When holding tissue under tension, use a power grip that engages the full hand for increased strength. As you may know, the force transfer from the left instrument handle to the tip is very poor. Some studies showed that when compared with an open surgery instrument, laparoscopic grasp requires 3 to 5 times more grip force at the handle to generate the same amount of the grasping force at the tip of the laparoscopy instrument. Here are some recommendations for robotic surgery. Keep surgeon's back, neck, and head in a straight alignment. Adjust the viewer height so that the back is not slouching. Adjust the viewer tilt to avoid the forward neck flexion and to ensure you look straight ahead, not downward. Place the forehead into the surgeon's console's headset with a very light touch. Do not push the forehead excessively into the console's headrest, especially when focusing on a case, as I described before. Take a full advantage of the 3D visualization to improve depth perception, and use the system's clutch to move the master controller to the center of the workplace. Use the armrest to offload arm weight while keeping the shoulder down. Do not squeeze the master controller too hard when you are conducting suturing tasks. Okay, we also recommend the following: pre-plan monitor position, table height, and the tool selection before the beginning of each case. Avoid prolonged static posture. Incorporate the micro break every 30 to 60 minutes, depending on the length of the case, and incorporate the pre and post-case stretch and stabilization exercises before or between cases and at home. Avoid uneven standing posture. Always try to reposition yourself. You may have room to adjust your leaning posture unless you try it. Here are some exercises and stretches for surgeons. You can find these exercises with the detailed instructions from the ACS Surgical Ergonomics recommendations. We plan to take some exercise videos in October at the Surgical Ergonomics Clinic and add these videos on the ACS Education in Surgical Ergonomics webpage in the near future. I believe this will help the surgeons add these exercises to their clinical practice. The ACS Division of Education and the Surgical Ergonomics Committee hosted the first ACS Surgical Ergonomics hands-on clinic at the 2022 Clinical Congress in San Diego, California. We had 800 square feet of dedicated space in the exhibit hall with 4 stations, including open, laparoscopic, and robotic surgery and a stretching exercise station. Using the ACS Surgical Ergonomics recommendations, the surgeons learned how to optimize their OR component placement and what exercises they could do. I also had a funded research study to investigate the practical impact of the hands-on surgical ergonomic recommendations education at an international surgical meeting. Because this was the very first ergonomic clinic, I had some concerns. How many surgeons will come to the clinic to learn? Will they be willing to learn? I remember having a big debate with an on-site physical therapist. She asked if I could buy some yoga mat, and I said, for what? And she said, oh, we need something for surgeons to lie down and then do some exercises. And I told her, oh, you must be kidding. All the surgeons coming to the clinical congress will be in a formal suit, tie, dress, shirt. No one will do that. Let me do that. I will be your guinea pig. And she said, if they don't try it, nobody will learn. She said, okay, I will buy the yoga mat, but we'll see what happens. And for my research project, I wondered how many surgeons would be interested in participating in the study. We had a very exciting result. Over 400 attending surgeons and surgical trainees visited the ergonomic clinic for the 2.5 days. According to the post-clinic survey, more than 95% of attendees reported learning new ergonomic interventions. Over 95% of the participants were willing to adjust their OR component placement based on what they learned, and over 85% were ready to start to learn the exercises. And as you can see here from this picture, I was completely wrong. Surgeons were so willing to lie down on the yoga mat to learn exercises. We received the following two comments very often. Where have you been? And what did it take so long? Here are some additional comments we received. Important part of the surgical training and could very well help to extend our surgical career if applied early enough. Needed to get this out to residents and the young surgeons before the damage is done. The booth was very influential and good learning experience. I think the college need to increase education about ergonomics. Great work. Every surgeon need to know that. Loved this and need more of it. Very helpful. It is neglected, but very essential. After a few minutes ago, I said that I had a plan to conduct a research study during and after the ergonomics clinic. Using the pre-clinic the registration survey, I recruited the surgeons with moderate or severe symptoms. Originally, the on-site physical therapist planned to tell each surgeons what exercises they should do based on their symptoms. Unfortunately, we were told not to do so because this might be seen as an offering the medical treatment. The physical therapist was licensed in Utah and the clinic was held in California. Therefore, each participant was required to have a consultation with a local physical therapist to know and confirm what exercises they learned from the clinic would be good for their symptoms. 27 very highly motivated surgeons committed to participate in the study. I say it again, 27 very highly motivated surgeons. A few months later, 26 out of 27 surgeons dropped out of the study. One stayed only because she was from the same state, so she had a Zoom call with our on-site physical therapist. All others could not meet the local physical therapist in 3 months from the clinic. Again, these surgeons were with moderate or severe symptoms. They really need to have professional help. Unfortunately, they did not have time to take care of themselves. Doesn't this say something? Therefore, I revised the research protocol for the 2023 ergonomics clinic so that the study participant would not need to have a PT consultation. Responding to the overwhelming excitement from surgeons, we hosted a second clinic in Boston last year. We had a 4 times bigger space than 2020 ergonomics clinic with more physical therapists and more stations. And the ergonomics clinic was also very successful with over 600 participants with very positive feedback. So we are going to have a third ergonomics clinic again at the Clinical Congress in San Francisco, California this October. There will be some changes. For the first time, the pre-registration fees will be required to participate. We'll open the clinic registration the registration in a few weeks. So there will be an institutional, the group reservation, up to 20 surgeons, or individual surgeons can also register for the clinic participant. And in addition to the surgical ergonomics clinic, we are going to have a surgical ergonomics industry experience area. This dedicated space adjacent to the ergonomics clinic will have an industry to showcase and demo their ergonomic devices or tools. So we are going to recruit several companies with ergonomic instruments, anti-fatigue mat, shoes, loops, or other exoskeleton or ergonomic chairs for like a microscopic surgery. This will allow surgeons to try different ergonomic options in a single space, single place after learning about how to improve their ergonomics in the OR. So more details about the registration and the booth information will be posted on the ACS Education in Surgical Ergonomics webpage soon. And please feel free to let me know if your institution are interested in participating in this clinic.
On that note, Dr. Lee, there's actually a question on that note, if you don't mind.
Yes.
The audience, they enjoyed the ACS ergonomics clinic, they said, and they thought that the Da Vinci, I mean, I have to use the word obviously here, the Da Vinci console is not very ergonomic. They thought the new console, the DV5, seems to be better. And is there any collaboration with industry or the robotic company specifically in developing the new console? And do you have any data in comparing ergonomics on the new console? or it's
So thank you so much for the question. Yes, I have heard and so the video of the DaVinci 5 system, and yes, the old version of the Surgeon Console, even though it offers many the ergonomic features, what I found is many surgeons that don't use it at all. When I made a presentation at the Korean Surgical Society, the annual congress last year, one of my friends who's been doing the robotic case for the last 12 years emailed me and said that after your talk, I finally created in the account at the console for the first time and I saved it. So I asked him, so what have you been doing? And he said, oh, whatever surgeon setting, console setting was there, I was simply using it. And also, when I spoke to many surgeons, Intuitive tried to teach some how to adjust the things, but it is very brief and not many, the many remember and know how to do ergonomically, the correctly set up, use the features. So yes, I believe the old version of the console had something to be improved, and I haven't tried the DaVinci 5 yet. Actually, next month I'm going to an event, the local event, to try and see. And it brings the visor, the viewer, to you, so you don't have to bend your forehead, your torso to get there. So I think it will offer better. But in terms of like a static posture, it doesn't change. And pushing their forehead, I don't know what kind of a cushion or suspend the mechanism they have on the forehead, the headrest. But if surgeons still push it hard, it will have some issues. So, but we are collaborating with Intuitive, and I personally provided some feedback. I hope they make more changes.
what variable, I'm curious, what variable do you use to compare? Like, do you look at how do you, for example, measure neck strain? I've seen, literature, in open surgery, they've measured even things as detailed as leg volume in, for open, standing surgeons. How can you compare between, let's say, two approaches or, one robotic console with another? Like, what variables do you look to compare?
So it is hard, as you just mentioned, like, I used to use the electromyography to see the muscle activation patterns when you are actively moving things around. When you have a neck static posture, it is not really involving a lot of muscle activation. So when you use EMG, it may not say, you have any ergonomic risk factor, but just maintaining the same posture for a long time, yes, even though it is ergonomically good posture, the neck has a strains. So what you can do about it is like once every 30 minutes or 60 minutes, you just need to step away whenever it is safe and possible, and then do some exercises, because that's what we normally do. Like when we are working on the computers, when my neck started stiffing, I just move things around and try to lose it. But how to measure it? It should pretty much how long do you maintain the static posture, by looking at it. I don't think the EMG can really help you to differentiate, one system neck posture versus the other.
From the other. And you mentioned a few stretching exercises. I don't know if you'll talk more about them, or can you just maybe tell the audience like what can be done in the OR? You just mentioned it right now, versus things that can be done at home, before or after surgery.
So because I am not a physical therapist, I don't feel comfortable teaching you how to do those exercises. But the ACS surgical ergonomics recommendations have all the details and what to do. So it's like the neck exercise doing this, and then you have some, the chin down kind of exercises. But more importantly, I believe the surgeons should be treated as an athlete. The meaning is, the many surgeons, open surgeons especially, came to me and said, we need something, but there are not many things we can do about it. That is true. So what I decided to do is actually developing not just the exercises you can stretch and then release some tensions in the OR, but actually you should work to strengthen your exercise, your muscles, and be prepared. Like an athlete, if someone just stretch a little bit before they're just about to race, it doesn't work. They actually prepare all the muscles for the job. Until we have, the many ergonomic solutions that came, coming out for open surgeons, for example, I think the best recommendation would be surgeons actually doing a lot more strengthening exercises before development of all those ergonomic issues, and have them prepared and strengthen them so that at least we can delay the onset of such problems. So that is what I am currently working with our physical therapists to develop new set of exercises for strengthening and preparing the muscles for the job.
Okay, thank you.
Thank you. Okay, and so we also offer a new on-site surgical ergonomics training program. The several institutions told me whether ACS could bring this the ergonomic clinic to their institutions. So we have we are going to have the first on-site surgical ergonomics training at the UTMD Anderson this September to train their around 150 surgeons in 2 days. So we are going to have like a half-day didactic session and followed by the hands-on clinic for 1.5 days. So if your institutions would be interested, please let me know about it. Before ending my presentations, I would like to share some tips. Considering that surgeons' main focus in the OR will never be their own wellness, I strongly suggest the surgeon recruit somebody who can help your help to be your ergonomic buddies. The main role of these ergonomic buddies will be helping surgeons building new habits. This ergonomic buddy can be somebody who come to your OR regularly. So it can be your the resident fellows, a nurse, or the tech, or someone else in your OR team. You may find more than one buddy because you cannot expect someone to be with you all the time. The ergonomic buddies may have several roles. So prior to each case, ergonomic buddy will ask you if you did exercises before coming to the OR, and also ask if you adjust the OR component following the ergonomic guidelines. During the case, your ergonomic buddies will remind you to some intraoperative stretching exercises at certain intervals. After the case, the ergonomic buddy will remind you of the exercise you can do between cases or at home. According to the research survey data I conducted, those who designated ergonomic buddies are more likely to implement the learned exercises in their practice and more likely to continue those interventions for a long period of time. I believe we need to make some changes to the culture of surgery. The first step would be increasing the awareness of the importance of surgical ergonomics. Many surgeons who came to my ergonomics clinic did not know much about the surgical ergonomics at all. I'm happy to hear that the surgery department plan to host their ergonomics grand round to discuss the surgical ergonomics. And I'm so glad your society decided to have this webinar. And I hope that this audience would not be limited to the surgeons, but include the hospital leadership and those in the wellness and the workplace safety programs. If you are interested in hosting a surgical the surgical grand round and surgical ergonomics, please let me know. I can help you, or I can have someone from my committee as well. We'll need a safe report system for surgeons to share their ergonomic issues with the right party. Their ergonomic issues, surgeons' ergonomic issues report should not be used against them later. Recently, we talk a lot about the resident wellness. I think it is important to have a more ergonomic related conversations between resident and their attending surgeons after each case. To find more the better ergonomic settings working for both. During the last ergonomics clinic, I had many residents, and I encouraged them to discuss their ergonomics with attending surgeons. And they said, no, I'm not going to do that with my attending surgeons. And surprisingly, they were like a PGY 3 and 4. They should have a good working relation. They have good working relationship with their attending surgeons, but they said that they're still afraid of bringing this to them. So any attending surgeons on this webinar, I beg you and I really encourage you to initiate ergonomic discussions with your resident from tomorrow. You promise? I hope we can make a change together.
Yeah.
Okay, and surgeons use a team approach to improve ergonomics in the OR, and surgeons can encourage even other OR team members to join the exercises when you do it. We need a well-established surgical ergonomic educational program to help surgeons. Earlier exposure to surgical ergonomic education will be very important to allow surgeons to learn the fundamentals of the surgical ergonomics and to look for more ergonomic options throughout their career. I think that ergonomic education during the residency is a must, and the one during the medical school would be very even better. We'll also need ergonomic education for practicing surgeons by their career stages. Hospitals may provide surgeons with easy access to a certified physical therapist to get some help and create an exercise room in the OR or near OR for surgeons so that they can do some exercises right between cases. The ACES Surgical Ergonomics Committee plans to do the following work. We are going to update the ACES Surgical Ergonomics recommendations. We plan to add more recommendations on open surgery and other surgical techniques such as endoscopy and the microscopic surgery. We also plan to work with the surgical device industry as more women come to the surgery and they experience some gender-specific ergonomic issues. Many female surgeons told me that they need to use both hands to fire stapler, whereas most male surgeons could do it with one hand. ACES Division of Education will also develop a simulation-based surgical ergonomics educational program. We'll have a series of the online educational modules, and we also consider offering ergonomic consultations to surgeons and their hospitals. As mentioned, the ACES has developed a program to offer on-site ergonomic clinic at individual institutions. Okay, here is my email address and the URL of the ACES Education in Surgical Ergonomics webpage. And we are going to update the current webpage in a few days. So stay tuned and we plan to have more the useful information and tools for surgeons. Thank you so much for your attention.
Great, thank you, Dr. Lee. This was a very informative talk. I saw you mention something about women and industry. A complaint I've heard from surgical residents is mostly the endoscopic tools, they're not really tailored to residents or operators with smaller hands or maybe righty lefty. Any more specific comments on that before we leave the floor to Dr. Durrani?
Yes, sir. So when I discussed with the surgical industry, they told me that there is there is no market for that because at the time the majority of the surgeons were male, and we didn't really talk sorry to the resident and trainees. We didn't really think about our trainees because most of the time the senior surgeons were making decisions, what kind of tools we use. But we now have like half of the surgical residency program have the women surgeons. And so that they started listening to it, and we are going to advocate that. And I heard that actually some company came up with the 3D printing handles for the laparoscopic instrument so that it can be smaller and it can be customized and they just switch it. I didn't see that yet, but hopefully we see that the company's product at the ergonomics experience area this coming October. So, but we are going to create. We already are in the process of creating ACS surgical ergonomics industry focus group. So we are going to continue our discussion with them and advocate that we need the support by the industry making instrument for smaller hand. By the way, 2 years ago, at the Division of Education collected the hand size and the grip strength data from those who participated in the clinic, and we are writing the paper out of that, which may be another tool for us to persuade the surgical industry to come up with solutions for smaller hand surgeons.
Okay. Great, thank you so much. Dr. Durrani, I know we've written on surgical ergonomics, and you've got, I think, a lot of input. Part of our audience obviously is cardiac surgeons, and I don't think any resident or trainee, we thought too much about headlights or loops and next train before we did embark on our journey in CT surgery. So if you would like to give us your insight on
Sure. Well, first, thank you, Dr. Lee, for a nice, informative talk. And I agree with everything you said. I think that I would just frame the discussion that the surgical specialties are different, and a lot of the recommendations that you're talking about may be good for one specialty, not necessarily good for another. For example, our audience is cardiac surgery. I mean, we're operating on a clock. Once the operation starts and we're on bypass, we're not taking breaks. We're not going over and stretching in the corner. I mean, we got to get the operation done. Now, with that said, I think that the place and the time for exercises is outside of the hospital, and you didn't really get into a lot of specifics, but it comes to a few simple things for me. It's core exercises. It's sit-ups, it's push-ups, it's planks, it's thing to strengthen your core muscles, and it's a lot of range of motion of things for your neck. I mean, that's just very simply put some things that one can do that help. And of course, the physical therapist, can get into very specific things for an individual if they're struggling with a specific problem. But in general, it's core strength that you need as a surgeon. I think general rules, and since the audience is cardiac surgery, I would say the following. You want to stand. I use a mat just like you do, the same mat. You call it the princess mat, whatever it was. That was a nice little acronym for it. I've been using that for years. Knee socks to try to minimize, varicose veins. And I think you want to stand straight as much as possible and keep your neck straight as much as possible. Now, with that said, that's not a practical strategy for at least a cardiothoracic surgeon, because we are changing our body positions a lot during the operation. We're sitting for portions of it, we're standing, we're bending over. I mean, it's not as simple as, say, like a dentist who sits in the office. They look through their loops for a very specific thing, then they can take their loops off, and then, they can, look around. So for us, the loop that you showed is the loop that's been getting a lot of visibility, where your neck is perfectly straight and the loop comes down. I've tried all sorts of loops. That is just not a practical loop for a cardiac surgeon. And the reason is because for a cardiac surgeon, we are looking around the loop a lot during the operation. We're looking up at the monitor at the hemodynamics. If we want to look in the incision without looking through the loop, ideally, you'd want to look below the loop so you don't have to turn your head way over and look over the top of the loop. Or you may be turning around and talking to anesthesia or perfusion. And so there's a lot of activity in the OR where you're not looking through the loop. And then, of course, there are specific, aspects of the procedure where you are looking through the loop. And so a couple comments about loops. They have different focal lengths. And a lot of people that wear loops don't like their elbows at 90 degrees. I do like my elbows. My focal length is 20 inches, because at 20 inches, my elbows are at 90 degrees. That's how I like them. But a lot of surgeons with loops like their hands a little closer to their face. And so the focal length for surgeons varies based on that. The next thing is that, and I'm not advertising any loop. The loops that I have, you can adjust the loop to where you want it. I don't like most of the loops on the market because the frames are big, they're light, but the loop is very low in the frame. It's very low in the frame, so that when they're looking through the loop, their neck is at 30 degrees. But for us in cardiac surgery, if you don't want to look through the loop with those loops on, then you got to do this to look over the top of the loop. It ruins your neck. And so I like to adjust my loops so they're more in the center of the frame, so that I can look above and I can loop below without actually moving my neck. And the only time my neck goes to 30 degrees is when I'm looking through the loop. So and then do you wear a headlamp, or do you put the headlamp on the loop, or you put the light on the loop? So my loops are 3.2 magnification. I use 3.2s for everything. Some surgeons like 2.5s for some things. I like 4s for something else, and they'll switch them based on the procedure. I don't think that matters, but a 4 magnification loop is a very heavy loop on the nose. And so if you're doing a long case with that loop, it is hard on the neck. And so, you need to keep that in mind. I like the headlamp around my head. And for a long case, you can get a headache. I have a foam strip inside to try to minimize that. I don't like the lamp on the loop because it makes so much weight on your neck and on your nose, with it on the loop. So, but some people like that. So I think it really varies. But for cardiac surgeons, I think the message is that there's a lot of activity in the operating room where you're not looking through the loop. And that is a very important, factor to consider when you're buying loops, because you want to avoid having to look over the top of the loop into the incision, which causes a serious, flexion of the neck to do that. And those are just some general comments. That there's no hard and fast rule for everybody. Some plastic surgeons doing hand surgery sit, and for 90% of the procedure, they're looking through the loop. They're not looking at a monitor at all. And so the loop that you showed where, your neck is straight and, the loop comes down works great for them. But for a cardiac surgeon who's going to take down the internal mammary artery, is going to be sitting down for that. There's no way to use that loop practically for that. So you want to find one that's comfortable for the majority of your procedures for the whole entire procedure, because you don't have the ability to keep changing loops in the middle of the operation. And those are some of the things that I've learned. And I think that you just need to find out what works well for you and stick to it. So Dr. Hassan has a question.
Dr. Durrani, thank you. And Dr. Lee, both really outstanding presentation and great comments. And I'm Dr. Durrani, I really think it's important to emphasize the comment you made about core strength, because I think a lot of people don't quite appreciate how important that is. And then I also think the counter to that is also flexibility. And when I think about what's the exercise type of program that really is both core and flexibility, the one thing that comes to mind is yoga. And I'm wondering, is there any data that out there about the benefits of yoga as it relates to the kind of work that we do and the durability that it may be able to give us in order to do our work for a longer period of time?
Well, I do Pilates, and I think Pilates is probably, maybe a more, I think yoga is great. I do want to look into the yoga thing just because my daughter does it, and she really, she's a fitness coach and she's into all these different things, and yoga seems to be something quite good. But I will tell you, Pilates is something that more surgeons are doing, particularly with the reformer, because it does just what you're talking about. It's a combination of strength and flexibility. And when I first started doing it, although I'm on a hiatus right now, my wife and I started doing it together because it was something for us to do together where we were having fun. And we were also doing something practical. I told the instructor exactly what my issues were. I'm standing on a mat sometimes for 4, 6. I mean, the other day it was a terribly long case. It was 8, 9 hours without me actually leaving the operating room. And now that's the exception, not the rule, but it is very common for a cardiac surgeon to be standing for 4 hours at a table without taking a break. That happens every day for many cardiac surgeons. And I showed him my body positions and I showed him the kinds of things. And, actually my lower back bothers me more than my neck, because I do think I have the loop thing figured out so that it works well for me. But Pilates, I think, is a very practical thing that incorporates both strength, because you're doing it against some resistance, and flexibility. And I suspect the yoga is probably, maybe runner up, but Pilates would be the thing that I would encourage surgeons to consider and look into.
Yeah, these are great comments. I think I'll give you my perspective a little bit as a thoracic surgeon doing robotic surgery. What I found to be, among other things, I mean, I do also still VATS, sometimes open endoscopic surgery, but I found doing robotic surgery and having a dual console with a trainee does help me. It gives me the excuse to stand up, leave the console, let the residents do their work, and actually I stand up on purpose and walk around, and I stretch a little bit, and I show them on the monitor, because they gives you the option of showing them on the monitor what exactly you want them to do, not just on the actual console. I did find this helpful over the years, gives me a little bit of break. Obviously it's not possible, I think, for open surgeons, not to the same degree. I think I've also noticed personally, the strain, the pattern of strain is different. Sometimes I feel like my I mean, I don't have carpal tunnel, but I feel like there's a bit more strain on my wrist with robotic surgery compared to let's say VATS or open surgery. So, but you're definitely correct. The recommendation there, I don't think there's one size fit all, and it depends on the specialties, even on the individuals. I meant to ask Dr. Lee. He mentioned there was no good correlation with the age, I think, when they looked at the patterns of strain or injuries. I did read there was one study, I think, in JACS. They found a higher, I think, symptom rate in male surgeons compared to female surgeons, actually, both in the oncologic surgery practice. Has he noticed any, has he come across any significant differences in terms of gender, age, or specialties, at least in general surgery?
What I remember from my study, there was no big difference between the male and the female surgeons from my data set. But again, it was mainly from the general surgery. So as you said, depending on the surgical specialty, and I totally agree with what Durrani and you mentioned, like a cardiothoracic surgery. Then these recommendations were created to be first step of the general recommendation, kind of to be universally used. But I totally acknowledge that probably the next work for the American cardio surgeons should do is develop looking into the specialty focused, and then develop the specialty focused the recommendations. I think that would be very helpful, because some do more the microscopic surgery, some do like the sitting, some do the standing, and as Dr. Larry said, the cardiothoracic surgeons that don't move around, which is different than the other the open surgeons as well. So I think it is important to look into the specialty, each specialty, and see what kind of recommendations we need to come up. And the core exercise, that's exactly what we are working on developing. But a little bit careful with the exercises, because like someone with the back pain, especially, depending on the cause of the back, some exercises will help. Some exercise can actually worsen your the symptoms. So if someone has a lower back pain, especially, please have your symptoms discussed with the licensed professional. So what you're planning to do to help you will not adversely affect your the lower back issues.
I know you're probably going to want to wind up, Dr. Bakos, but one other thing that we didn't talk about, because residents are involved, but back to looking around the loop. I mean, one surgeon is primarily operating, and another is assisting, and the assistant surgeon is oftentimes not looking through their loop because they're trying to keep things on the field organized, or trying to keep sutures from getting tangled and stuff like that. And so this constant, back and forth of both looking through the loop and not looking through the loop is something that needs to be, factored into the equation for it to be practical. And so I'm very particular when residents come and ask me, is to make sure that they can look all around the loop without having to bend their neck. And a lot of these loops, I noticed the loop is so low in the frame of the glasses, there's no way to look below the loop at your operative field. And that is just not a practical thing to do, particularly if you end up getting into an assistant mode, because then to look at the operative field to keep things from getting tangled, your neck is really flexed. And that is, I think, the worst thing, for your neck, is that excessive flexion. So keep that in mind. And the other thing I was going to say for Dr. Lee, one of the things that we're going to start doing here is once a quarter, have a physical therapist give, a talk to, to our resident staff and whichever attending staff is there, about exercises for surgeons and things like that. And you're right, if you have a specific problem with pain in a specific area, it probably requires you to be seen by an orthopedic person or somebody where they can do an x-ray and make sure that there isn't an anatomical problem that really needs to be addressed before diving into a bunch of exercises that could actually make the problem worse.
Thank you. Great comments. I think we have another minute or so. This was, I think, a great discussion. I think there's definitely more awareness about surgical ergonomics. We didn't really talk too much about it. We've mentioned it. I think there's still, I would say, a lack of dedicated ergonomics curriculum in most residency programs. But again, there's more awareness now. Dr. Durrani's example about bringing a physical therapist is a great one. I think that will help tremendously our future trainees to hopefully have a long and healthy career. Unless there's any other comments or questions, I would like to thank the audience, the panelists, Dr. Lee, Dr. Durrani, Dr. Ehsan, and Stan for organizing this and helping organize this. Thank you again. This was recorded. It will be on the ECTSS website. And I appreciate everybody's participation.
Thank you for including me.
Thank you.
Great discussion.
Thank you.
Bye-bye.